Thank you, Chairman. Good morning, everyone. I'm very honored to be invited in this symposium as a highlight symposium guest speaker. So, I would like to talk about the shoulder injuries in the overhead throwing athlete. But the time is limited.
를 잘 넘겨야 돼요.
This video
일부 바깥쪽의 볼입니다. 어제 적절하게 또 유무도 잘 던져야 돼요. 2구는 높게 뜨면서 왼쪽에 크로포드에게 잡힙니다. 공 2개로 일단은
United States of America.
네, 7시 시작하고 말씀드렸는데 바깥쪽 좋은 점입니다. 들어왔습니다. 빠른 공 카운트 떨어지는데 파울입니다. 커브를 던졌습니다. 스타디움.
2016, because of the another injury, elbow injury, is he got another procedure, operation, the elbow development arthroplasty. And this season, his score, he come back to stadiums, but his score is not good, but we expect it 2018. As you know, he is the Roger Clemens. Roger Clemens is one of the famous, the superstar in the Major League Baseball pitcher. So he was a rookie in 1984, but in 1985 he got the surgery, rotator cuff surgery in 1985. But he had 6 Cy Young Award and 2 World Series titles. He is one of the representative, the Major League Baseball player with successful surgery. He is interesting. Do you know the patella-colon? Patella-colon is the very interesting cases. He still play in Minnesota Twins and pitchers. His age is 45, so he decided in stem cell procedure in 2010. At that time, the doctor said he's never going to play baseball again. So, supraspinatus, infraspinatus, teres minor. And this is glenoid. His labrum is around attached, and this is biceps. Usually the slap lesion is here, superior, anterior to posterior superior labrum lesion, including the biceps tendon. This is the slap lesion. Usually, overhead throwing athlete had some problem. Is rotator cuff tear or impingement syndrome is very, very common. The other common injury is a slap lesion here, the biceps tendinitis. And this is anterior inferior labrum of shoulder, is so-called Bankart region. You know, the Major League Baseball rookie in American League, Aaron Judge, home run winner, has got the surgery, maybe the last month in Bankart region. So, is overhead throwing athlete, most overhead throwing athlete got the posterior capsular type. I will explain later. But this is the common injuries of the shoulder surgery. You know, the slap lesion and the rotator cuff surgery is most common injuries. The other one is the Bankart region and retrograde shoulders like this. I will show you the pathomechanism of the overhead throwing athlete. The throwing mechanism consists of the 6 steps: the wind up and early cocking and rate cocking and acceleration, deceleration, and follow through. This cocking period included the pelvis and upper trunk facing home plate and external rotation, arm external rotation, and occurred. After that, acceleration phase from maximal external rotation to ball release, and deceleration is ball release to the end range of arm internal rotation. After that, follow through from the maximum internal rotation until pitch regains balanced position. And weight cocking is maximum external rotation position is the one of the most common injury in the slap region and rotate cuff injury. I will explain later. The back pain or knee pain. So the muscle fatigue is excessive pitching, muscle imbalance and weakness, and excessive capsular laxity can occur the shoulder injuries. Overhead throwing injuries typically result of repetitive micro-traumatic stress. As I mentioned in the previous slide, and posterior band of the inferior glenohumeral ligament contraction is very common. This is the compactive tensile loading to posterior band of the inferior glenohumeral ligament during the follow through. Here, this is the diagram for the contracted posterior band of inferior glenohumeral ligament, thick and thin. So every overhead throwing athlete with the shoulder pain has a GERD, glenohumeral internal rotation deficit. This sequence, the glenohumeral contact point will be moved posterior superior shift like this, and during external rotation, excessive external rotation position, so like this. This excessive abduction and external rotation position has some abnormal mechanics and reduced cam effect on. It's hard to explain to this mechanism. This is the sequence to the dead arm sign. It's peelback slap region and impingement of the posterior rotate cuff. So we can have the articular surface of partial rotate cuff tear. And the other one is we have to consider another factor. The throwing a ball requires a transfer of energy from the feet through the leg and the pelvis and trunk out through the shoulder and elbow and hand. So the ball velocity depends on the energy transfer efficacy. Only 50% of kinetic energy imparted by upper extremity. This means the lower extremity, the lengthening is very important. If the athlete had hip weakness, they can have the shoulder and elbow dysfunction. And this is saying the pelvis and trunk motion during the baseball pitching is associated with ball velocity. So limited in hip and spine flexibility may adversely affect pitching by mechanics and ability to generate ball velocity. This is why Hyunjin Yu had the second surgery of the elbow, I think so. This is a diagram for the pathomechanism of shoulder injuries. Hyper-external rotations means repetitive hyper-external rotations might have micro-trauma and posterior capsular tightness, impingement, rotate cuff tear, slap lesion. This means the muscle weakness can occur. The scapular dyskinesia is very complex correlations. The Yong-Gyu Lee is Korean, the professional baseball player. He got the long time of pain of the left side pain. So he got the slap lesion and the medium side rotate cuff tear. He got the surgery and the slap repair and rotate cuff tendon repair is successfully again to the stadium. Now is I will explain the rehabilitation protocol for the overhead throwing athlete. Rehabilitation program for the overhead throwers, we have classified 4 phases. The first one is acute phase. Phase 2 is intermediate phase. Phase 3 is advanced strengthening phase. Phase 4 is a slowing program initiation. This is phase 1 treatment. The goal is the decreased inflammation and pain, and increase flexibility and normalize range of motion, and establish dynamic stability and retard muscle atrophy and restore proprioception. So the modality to decrease the inflammation and pain, we can have the cryotherapy and ultrasound and electrical stimulation. Exercise included in strengthening for it's a phase 2 treatment included continuous strengthening, stretching and flexibility and progressive strengthening program. The slowest 10 program including the rotator cuff strengthening, you can find the internet on the slowest 10 program, and core strengthening and lower extremity strengthening. This is core strengthening, diagonal pattern flexion, and the leg press in the squat. The ball crunch, wall push-up is included in the phase 2. Prone extension, prone rowing into external rotation is included in phase 2 exercise. Phase 3 treatment, the goal of the phase 3 treatment included in begin aggressive strengthening and increase power and endurance, and it begins like this. Finally, we have to move the phase 4 treatment. This is begin with the shadow and the mirror throwing to work on the proper mechanics like this. This is very important. The criteria to begin throwing, the interval throwing program, you should keep in mind the design to gradually increase the quantity and distance and intensity. This is take-home message. All of the injuries, decision of treatment, especially operative treatment, very carefully decided. Rehabilitation is the most important in the overhead throwing athlete. Thank you.
For questions, if you have questions, please raise your hand and ask any questions. Yes, please.
But external rotation more than normal, they conclude this is normal.
Yeah.
Which means the bone have some architectural changes, and this is not a problem.
The rotator cuff tear, because of the glenohumeral contact point is the move to posterior superior area. So that's why the internal rotation girth is why important in the overhead throwing aspect.
Maybe.
Yeah.
So, super stretching is targeting a posterior shoulder capsule, and when you have a pain with the anterior shoulder, you can vary the degree of your shoulder to stretch the posterior capsule. However, if the pain is in the anterior, you may want to vary the degree of the shoulder position. If there's a pain in posterior, mostly the capsule, it's probably because of the capsule and infraspinatus anterior minor as well. So you may want to work on those two muscles and try to stretch the capsule. If there's there's a pain present, you may want to try to release the posterior capsule manually, and that'll work.
Yeah. I understand your point. Maybe the modification of the angles, or not quite well working for some athletes.
Yes.
Not well tolerated for some.
Yes. There's no problem with that because there are a lot of researches about the super stretch. However, there are some researches they suggest will be trying to stabilize scapula.
Yeah,
It will work a lot better.
던지는 동작에서 어깨 부상을 말씀하셨잖아요. 예를 들어서 이제 투수를 말씀하셨는데 저는 그 배구도 같은 비슷한 상황이라고 생각하거든요. 이제 같이 스매싱을 때릴 때 트렁크랑 같이 펠리스랑 같이 사용하는 그런 것이라고 비슷한 상황이라고 생각이 들어서 혹시나 그 배부 스매싱 같은 걸 때는 이렇게 부상이 일어날 수 있는 그런 종류가 좀 같은 건데 그게 좀 개념이 다른 건지 좀 궁금해요.
Yeah, I didn't include just I want to say just the time is limited. I prepare the baseball player. It is the same mechanism and the same volleyball player.
Is it possible to quantify the number of throw for the athletes every day? Because otherwise, if some athletes practice 1,000 throw, some athletes very hardworking. After the formal training session, they love to training with the colleagues and then throw a few more times. And then you didn't quantify how many times they have throw. Actually, they may have already overused the shoulder. I'm not quite sure because now it's quite common. Some other countries use the accelerometer or some equipment try to quantify the volume of the throw. I'm not sure if any similar ideas in Korea or in this area to do this. I just want to know more.
Trainer, so I do not the exact answer. I'm so sorry.
That's okay.
Yeah. In Korea, we recently tried to limit. Right, you probably agree with me. And in the States, in the United States, it's probably the same problems. They have the law that young athletes cannot throw. I believe it's like 70s in like around teenage 12 under 12. But athletic trainers and personnel in sports medicine, they began talked about we really need to limit that much or a little bit more. Like they talked about Japan and Korea that those pitchers in Korea and Japan, they throw more numbers of balls and they're still okay.
Volume to prevent the injury.
Some coaches try, some coaches don't. We don't have really regulations for that. We are trying to have that regulation. We're still having our problems. We're trying to figure out. How about
Hong Kong, only 1 or 2 teams about the baseball. Nobody play baseball almost.
Same here. Yes. How about Japan? Japan's probably, well, in Asia, best baseball players. So, what about the throwing limitation in Japan?
Maybe we would have to follow the United States rule. It's very limited in
That'll probably increase speed and increase performance of the pitchers. At the same time, preventing injuries.
Thank you.
Any, was that?
Yeah, okay, thank you. Good.
Any other questions, please? Thank you very much, Dr. It's from 늘 열린 성모 Hospital, Korea. Dr. Lee is an orthopedic surgeon, currently working as a director of orthopedic surgery at 늘 열린 성모 Hospital and medical advisor of Neighbor. He received his medical doctor's degree from Chondral University School of Medicine and completed internship and orthopedic resident course at Daegu Fatima Hospital. He had worked before as a director of orthopedic surgery at Sammo Hanmi Hospital, Susong Hanmi Hospital, and Bumi Gangnam Hospital, and had been to Penn State Hirsch Medical Center Sports Clinic, Columbia University Medical Center Sports Clinic, and GO Hanover Sports Clinic.
Yeah, this is right in the surface landmark. We can easily see here is patellar, and here is the tibial tuberosity, and then femur and tibia. This is brief light knee anatomy. We can see femur, tibia, and then there is some important structure between 2 bones, named the cruciate ligament. There is an anterior cruciate ligament and posterior cruciate ligament. So, and then there is 2 more important structures like this meniscus. Yeah, this is a hinging. You can easily show like this like joint in here. The joint is well known as a hinge joint, but there is not only flexion and extensions, but also some rotation and gliding. That's the reason why ligaments are important of stability and vulnerable to injury. There is so many intra-articular diseases or injuries, cartilage, ligament, meniscus, plica, patellofemoral alignment, loose bodies. But we have some time limitations, so today I will talk about ACL and MCL. Yeah, he's the well-known PGA golfer named Tiger Woods. It's a famous his ceremony to win a game. One day he complained of his knee pain during the playing. And finally he interrupted the game because of knee pain. Yeah, this guy is a famous Korean soccer player named Dong-Guk Lee. He's made a player of the 2006 Korean World Cup team. His shooting was so fantastic. He dropped to the ground during the game just before 2006 World Cup game. Let's watch a video clip of his injury time. Yeah, this is 2006. But we can easily see he bandaged his right knee from since his 2000. So I inferred the result he had injury knee injury at that time, maybe. This is a arthroscopic view of normal ACL on right knee. There we can see healthy and strong ACL. You can easily match the direction of ACL. The ACL direction is like some of your hands like this. This right knee, this is left knee. So this right knee is ACL. This is acute tear of ACL ligament, tear from the femoral attach. You can detach it here, and we can dislodge the ACL with some hemorrhage here. This photo taken from a wrestler. Whole ACL was melted away, so we cannot see any fiber ACL, just their ligament here. There's no ACL. This is PCL and just ligament is here. As you see, the mechanism of ACL injuries, sports involving pivoting and decelerating suddenly, and 85% is non-contact injury, and 75% is total ACL tear, and valgus and rotated upper side, hyperextensions. This is one of the best photographs which shows the injury mechanism of ACL here, named the dynamic valgus. This is beautiful swing sequence of Tiger Woods. Yeah, but we concentrated on his left knee. At the final throw, his left knee was fractured and twisted. And large tensile effusions within 2 hours. And this is the most common cause of ham arthrosis and field instability of leg of confidence. You can easily detect your right knee fusion here. If you had some regular during the playing game and then something wrong, and you get 2 hours. Within 2 hours, we have this kind of thing. You should go to see a doctor. There's some trouble with sorry. this is performed in the operation room. You can easily anterior displace the tibia. Lachman test is we the displacement to anterior is how much, and then you can feel firmness of the endpoint. If ACL injury, there is no firmness, no more. ACL reconstruction is performed with arthroscopic technique. I made a proper position of tibial footprint here, and then make tibial tunnel, and also made a proper femoral tunnel here, double bond technique. You can see there is 2 holes. That's that 1 or 2 decades, doctors debated 2 ways of surgery, single versus double bond techniques. Early 21st century, there is some reports about LCL's character. There are various surgical options and graft and fixation device. This one is patellar bone, patellar tendon, and tibia tuberosity, traditional one, and that one is Achilles tendon. There is calcaneus bone, and then this is a hamstring, autograft or allograft. So this kind of things was a 2 or 3 strand, even though 4 strand. So that is some difference from here. Some fixation devices, some are different from allograft, like this, some screws and some suspension ligament. I did the ACL reconstruction with allograft Achilles tendon. So we can see here, lateral screw. A few years later, he got injury on his right knee, and he was interested in some trend changing in operation techniques. He got information from internet or some SNS, so many cafes. So he wanted to bring new technique in his right knee. So I performed his right knee ACL reconstruction with his allograft. His autograft, we use this. A few months later, we can see well-healed and well-synovialized ACL here, like here. As you know, female players have a higher instance of ACL injuries than male, even though 3 or 4 times. Some causes reveals, and please pay attention to this female volleyball player. Can you see? Once more, his left knee. There's a familiar form of a dynamic balance. So, some trend is so neutral alignment of lower extremity during landing is important for prevention. Next topic is the MCL. MCL is the result of backward stress of partially flexed the knee and non-contact or contact mechanism. This picture shows well mechanism of MCL tear. There's some direct force on that lateral side, just MCL tear and ACL, even though rather. Yeah, this guy is a famous Major League Baseball player named Kang Jung-ho. The video clip shows well mechanism of MCL tear. We can see there is that right here is the MCL, and then this is detached from this femoral side. This is a typical setting of arthroscopic surgery. I had kept thinking, I hope nobody get injured, someone who enjoyed sports, the player, even people. Also hope successfully turning into good treatment and rehabilitation. To do so, I hope we will do our best in whatever position we hold, then it just come together to form a good result. That's the reason I, other than appreciate this opportunity.
ACL 현황 측정 방법에서 라크만이나 드로월 테스트를 하게 되면 아무래도 충격이 없지 않아 있을 건데 그 테스트를 어느 정도 사용해야 될지.
The femur shift is so this full legs of patient. So this is not usual test with acute injury. And then anterior dural test was some false positive because there was some meniscus region here. So Lachman test is.
Because of the development of the technology, we have very many successful cases. But you must have experienced some bad cases too, if possible. I'm not. If you can share the bad experience, that would be very wonderful.
Yeah, it usually 10% because there was some time ACL has ligament extension, so it takes about 12 to 24 months or 2 years. So after surgery, a patient will feel free about 6 months. So 6 months to 2 years is a critical time for his injury. So he got a re-injury on operation back or upper leg is within 2 years. So skills and some muscle strengthening is so helpful to that period. And in fact, there is some technical error in doctors. Fortunately, I got not. I didn't have a headache.
Of course not. Thank you.
Thank you.
They didn't do well.
Yeah, that's the good point. Because I did surgery for about 10 years, but there is some painful memory about some people. But 2 or 3 years ago, I went to Pennsylvania or some other Columbia University. But in the operation room, I feel that they did not well more than me. But their result is good because their rehabilitation is so systematic and so professional. So I think this is the point of these lectures.
Thank you very much, Dr. Lee. Thank you. 2012 and became an assistant professor at Yongnam University in 2012. His research interests are foot and ankle disease, including hallux valgus, ankle arthritis, flat foot, and calcaneus fracture. More than 50 articles about foot and ankle department have been published and keep building up top-notch academic career for last decades. Please welcome Dr. Park.
Thank you, Chairman, especially for the ankle. It is a very great honor for me to stand here, and I appreciate to you. My topic is treatment. My topic is ankle sprain and chronic ankle instability. First of all, I apologize for changing topics. After initial injury, more than 30% of patients have experienced the sprain and persistent instability. This is the video. She is Senator Williams, who is the greatest tennis player. Maybe she's her mother. She left at the beginning. But afterward, her face became
a really strange thing.
very
A couple of
serious.
games ago, she had the trainer on, and she took about 4 games ago. She took that
Very
straight
serious.
off.
Let's watch the left ankle here.
Sprain.
Yep, left
Or
ankle. And the thing that's so upsetting is, yeah.
But in spite of the ankle sprain, Senator Williams won the game. And this is the reason why she is the greatest tennis player, woman tennis player. Among athletes with ankle sprain, 5% had to change sports, and 4% had to stop sports activity due to residual symptoms. Similarly, non-athletes, 6% 6% were not able to continue their previous job, and 50% require external support. That is because, therefore, having a proper treatment by professional for initial injury is very important. This is the lateral side of ankle joint. Lateral ankle ligament consists of 3 ligaments: anterior talofibular ligament, calcaneofibular ligament, posterior talofibular ligament. We call it ATFL, CFL, PTFL. ATFL is the weakest of the lateral ankle ligaments. It close to the ankle joint capsule and has been found to be the discrete capsular thickening. CFL is only extraarticular ligament and originated on the lateral malleolar tip, and it travels in oblique direction with frontally and posteriorly. PTFL is strongest of the lateral ankle ligaments, and it rarely injured in ankle inversion sprains. So why does repeated ankle sprains cause serious loss? Because repeated ankle sprain could cause traumatic ankle arthritis. Common ankle sprains happened by excessive supinations, including frontal flexion, inversion, and internal rotation. At this time, rupture of ligament occur complexly. ATFL injured first, and in more severe sprain, CFL could be damaged as well. However, when we have ankle sprain, you can see the video. Not only the ligament damage, but also the collision of the bone at the medial joint spaces occur. It is more important than the ligament injury. Like this. So repeated sprain can cause traumatic ankle arthritis. There have been no definite evidence between the severity of a cartilage lesion and duration of instability yet, but there is a study that cartilage lesions like this of the talus were found in 55% in patients with chronic ankle instability. Therefore, long-standing ankle instability results in degenerative osteoarthritis by unbalanced load on the medial joint space, like this picture, medial side. This is the reason why we need to treat ankle sprain actively. Lateral ankle sprain commonly are graded 1, 2, 3 according to the severity of ligament injury. Grade 1 is just stretching ATFL. CFL is intact. Grade 2 is ATFL totally ruptured, but CFL is partially ruptured. Grade 3 is post ligament totally ruptured. But it is very difficult to check the ligament integrity at the time of acute injury because of pain and swelling. Therefore, clinical grading usually is subjective and based on the amount of pain and swelling and ecchymosis. Anterior throat test and eversion stress test can be used to check amount of instability, but these tests may be difficult in acute injury because of pain and swelling. So, thorough physical exam, especially palpation, is very important in acute sprain. We check the location of tenderness, ecchymosis, and swelling. Careful palpation can confirm involved structures in injury. Some studies revealed 52% of patients with ATFL tenderness indeed had a ruptured ATFL, while 72% of patients with CFL had a ruptured CFL. X-ray is important to confirm ankle sprain associated injuries, such as PIPS, metatarsal base fracture, calcaneus anterior process fracture, osteochondral fracture, talus lateral process fracture, and the syndesmosis injury. MRI is not typically indicated for acute sprain. This is normal ankle, this is ATFL. But as you can see, this is the MRI of the patient with acute ankle sprain, severe acute ankle sprain. in the acute stage, we cannot obtain exact information of ligament injuries due to severe hematoma and swelling. However, if there are other suspected injuries, MRI can be useful to detect them. In acute sprains, ultrasound can be more useful for evaluation of ligament injuries because it allows for non-invasive and dynamic assessment of ankle. Acute tear, visualized as ligament swelling, discontinuity, hyperemia is similar. Most protocols emphasize strength and balance. Treatment for acute sprain is phased in. In stage 1, inflammation and swelling have to be controlled. If needed, crutch can be used. As you can see this graph, after injury, inflammation rests for up to 3 days. Therefore, patient have to use ice pack for 20 minutes every 3 hours and keep going for 3 days after injury. Treatment of grade 1-2 sprains is very straightforward and conservative management remains good results have been reported for these injuries with cast immobilization and functional rehabilitations. Although rarely performed, some investigators have promoted acute repair of ruptured ligament in severe ankle sprain. This is the indications for for surgery of acute ligament injuries. But according to the study, given the outcome of secondary repair are very similar to the primary repair. So I think that surgery is rarely indicated in the acute sprain. This is very interesting study about the best protection tool for severe ankle sprain. 4 different type of protection tools were used for 10 days after severe ankle sprain. Tubular compression band was used as the reference treatment because it was cheapest and most commonly used. And the result is very interesting. Balloon cast showed best clinical outcomes or build up the clinical outcomes, and air cast and Lateral showed similar outcomes. Therefore, they recommend balloon cast in severe ankle sprain, and air cast brace could be a suitable alternative for the cast, considering the cost. Stage 2 is time to restore range of motions and improve peroneal tendon strength. Common exercise use bandage was performed like this. When performing peroneal tendon strengthening exercise, it is important to perform the ankle with plantar flexion, not neutral or dorsiflexion, just plantar flexion. Next step is preparing to return to sports. In this stage, improving proprioception is most important and performed in various ways using various tools. This is the balance board. This is the gym board. And single limb standing with closed eyes is also a good method. I like this rehabilitation. Returning to play is multifactorial and every doctors have different conditions for returning to the sports. This is my standard. More than 80% strength compared with the uninjured limb in isokinetic test, and no pain and no swelling after 10 times skipping rope. If a player passes this test, proceed with exercise in following order. Next topic is chronic ankle instability. About 30% of patients with acute sprain progress to the chronic ankle instability. Patients with chronic ankle instability commonly complain pain and giving way. They said ankle is shaking, hurts when changing direction, no strength when jumping. There are 2 tests can assess ankle instability. This is anterior throw test. If there is instability, you can feel the clunk. This is barrel stress test. In patients with instability, you can see the suction sign. is different. However, various stress test is not useful because it is hard to distinguish ankle motion from subtalar motion. So anterior drop test is more commonly used in clinical practice. To confirm amount of instability, we check the stress test using the Telos stress device. In anterior drop test, more than 3 mm translation compared to the uninjured side, or absolute value of more than 10 mm of translation correlated to the ATFL incompetence. We collect the hind alignment to uteral. She's very happy. MRI is more useful in chronic ankle instability than acute sprain. Ligament injury can be seen on the MRI, just swelling or wavy type, or the thickening and the discontinuity or non-visualizations. And it is very useful to detect osteochondral lesions and subchondral fracture. Rehabilitation is also important in chronic ankle instability, and it is high successful rate in treatment in chronic ankle instability. Aggressive physical therapy for 3 months is recommended. If conservative treatment failed, we can perform surgical treatments. Indications for surgical treatment like this. Many surgical procedures have been described for chronic ankle instability. They can be divided into 3 categories: anatomic repair, non-anatomic reconstructions, anatomic reconstruction, repair of the ATFL and the CFL. This is original prostrom procedure. After that, Gould modified the prostrom procedures by augmentation using inferior extensor retinaculum. We call this technique modified prostrom procedure MVP. MVP is widely used because of the straightforward technique. Technique of MVP is very simple. It is some different depending on the surgeons. I will show you my technique. I use curvilinear incisions. I check the condition of ligaments and cut the capsules using anterior half of peroneus longus tendon. First, we harvest tendon, anterior half of peroneus longus tendon. This is peroneus longus tendon. We harvest tendon with 4 mm diameter and 20 cm in length. We harvest tendon, use the minimal invasive techniques using tendon stripper. After harvest tendon, we perform the ligament reconstructions. First, we make the talar tunnel in the talar neck. This talar tunnel, make it here. This is for the CFL attachment. And passing the graft to the pubic tunnels first, and fixed graft in talar neck using the bioabsorbable screw. After that, we make the calcaneal tunnel in the anatomic location of CFL. Pass under the peroneal longus and brevis tendons and fixed ligament using the bioabsorbable screw. There are several studies that reported good clinical and radiographic outcomes of anatomical reconstruction, but there are some drawbacks. such as longer open time, donor site mobility, and technical demand. Among them, donor site mobility, in other words, functional impairment, is more serious concerns in autograft harvest. We also had a concern about that, so we conduct a study that investigates whether harvesting the anterior hypoperoneal longus tendon decreases the strength of the ankle plantar flexion and eversion. We performed isokinetic evaluations after surgery and compared the result with uninjured limb. We found that no significant differences were observed between the uninvolved limb and involved limb in the mean torque for the plantar flexion and eversion. Post-op rehab is also important after ligament reconstructions, but protocol is different among the physicians. This is our protocol. We apply Chondral cast post 4 weeks and permit weight bearing with cast at 2 weeks after surgery. At 4 weeks after surgery, cast removed and replaced the L cast and dorsiflexion, only dorsiflexion exercise and peroneal tendon strengthening exercise start. At 6 weeks after surgery, right jogging and full range of motion and proprioception exercise start. We permit return to sports at 3 months after surgery if there are no pain and no swelling after 10 times of skipping rope. In summary, functional rehabilitation is important in treatment of acute ankle sprain. In severe ankle sprain, more constrained protection like a cast is better than other protection tools. Conservative treatment should be also considered first in the treatment of chronic ankle instability. If that fails, surgical treatment may be considered. After ligament reconstruction, functional rehabilitation is important to obtain best outcomes. Thank you for your attention.
How about 100, so how you differentiate if they actually go back?
No pain, no swelling.
So you mean after 100 times?
Yes.
No pain, no swelling?
No pain is more important.
No pain is more important.
This is just my standard.
Okay.
My standard.
Okay.
Any other questions, please?